Very little time left, and was going to cover managing limbal stem cell deficiency. I'm going to go over it very quickly. Now, we know what are the various etiologies of limbal stem cell deficiency and what are the clinical features. The diagnosis is predominantly clinical, and the basic changes will be vascularization. Slides. Okay. So vascularization of the cornea appears dull and irregular, and the patient will have an uncomfortable eye. So the key features are the conjunctivalization with opacification and disruption of the palisades of Vogt. Impression cytology is not essential. It would be more required if you were doing a particular study. Basically, you're looking for evidence of conjunctivalization of the cornea by the presence of the goblet cells. We standardize the technique if you're going to have the impression cytology done by an external lab, where depending upon which area you're taking the specimen from, you have different shaped filter paper strips so that the lab knows which is the area from the limbus, which is on the cornea, and which is on the conjunctiva. In certain situations, there may be goblet cells absent everywhere on the conjunctiva as well. So that is why it's always good to have a control. Now, you have to assess whether it's unilateral or bilateral, partial or total, what is the vision, what is the visual problem the patient is having, whether it's uncomfortable, and whether the eye is inflamed or quiet. This is important because doing any limbal stem cell transplantation procedure in an inflamed eye is unlikely to succeed. So it's very important to try to get the eye to settle down. And often you will find just by tear substitutes, fornix reconstruction, controlling of the lid abnormalities, and controlling the inflammation, the cornea may clear up and the patient may get reasonable vision. And if that doesn't succeed, then you have to go for a procedure to restore the stem cells, with the concept that when you're replenishing the stem cells, the environment or the host environment has to be conducive. So you require adequate lubricants, we require a stable surface and a healthy substrate which is not inflamed. So you have a conservative do-nothing approach, and if it is unilateral, one would do an autologous stem cell transplant. If it's bilateral, then you're looking at an allograft either from a relative or from a cadaver, or you could consider of non-ocular sources such as the oral mucosa. Now, looking at a conjunctival limbal autograft, it is similar to what you do with an autoconj transplant for a pterygium, and it can be supplemented with adjuvant amniotic membrane transplantation. Bilateral cases you can take from a living relative, and there is a risk of rejection, of course, so you do have to use systemic immunosuppression. We have looked at the clinical results of live-related transplants. This also does well. So if you have a bilateral disease, you can use a live-related transplant with meticulous care, close follow-up, and a titration of medication. All techniques actually do give good results. So it's just a question of how you recruit the patient and do the careful care in follow-up. This is another example of a live-related allograft, and here again, remember to counsel the patient. You're not going to be able to get the eye exactly as it was before you had the injury, but what you're aiming to do is improve it from how it is. So there would be clinical improvement in vision, patient comfort, as well as clarity. And we have compared live-related allograft versus a cadaveric stem cell graft, and we felt live-related allograft was better, but this is not to say that a cadaveric graft doesn't succeed. That can also give good results. It's just that you require more systemic immunosuppression. So this is an example of cadaveric limbal stem cell transplant, and here's another example of a cadaveric keratolimbal transplant. So allografts, as we see, the evidence shows that it is a better option if it's live-related in terms of early re-epithelialization, earlier visual rehabilitation, and better visual outcomes, and lesser complication, less rigorous follow-up. These are the examples. As I said before, both procedures do give good results. If you compare both, you would say as a good outcome at 6 months. One benefit of a cadaveric allograft is you can take much more tissue. So at one one go, you can do an annular corneoscleral allograft. And the other way of achieving this is by doing a large diameter LK. This is particularly useful if you have a thin cornea, and at one stage you are able to restore the stem cells as well as restore the vision. This is the technique of large lamellar keratoplasty. It is a manual technique. And then you come to the concept of cultured limbal stem cells. Here you can harvest them from a cadaver or from the other eye if you're planning autologous. So CLET adapted technology in Indian setting to have less expensive interventions. And again, it has been shown in various scenarios that you are giving now a confluent sheet of cells. At one go, it is supported by autologous serum human amniotic membrane and using a cGMP facility. So the CLET journey from bench to bedside, it is confirmed that the cells can be cultured, they can be transplanted, and the patients we have operated have later on gone on to have DALC, and the nature of the epithelium has been found to have been corneal in characteristics. So cadaveric allografts can be used to grow cells as well. So you can use a cadaveric CLET. And autologous, if you look at the donor side, it's not that it produces any harm, but it takes about a year for the donor side to heal up completely, and the palisades of Vaux reconnect, and it becomes completely restored to how it was before. So this is another example of a confluent sheets and autologous and unilateral chemical burns. Now the post-op care is important. So actually you have to be very careful. You may have to give steroids for a little bit longer. Beware of steroid-induced glaucoma, and sometimes you may have to also support it with cyclosporin A or topical tacrolimus. Systemic immunosuppression is a very extensive regime with 3 medications: oral steroid, a lymphocyte inhibitor, which could be cyclosporin or tacrolimus, and an antimetabolite, which is azathioprine and mycophenolate. So this is one big negative against allografts. Then failure, there could be various causes. There could be rejection, there could be late failure due to sectoral conjunctivalization, dry eye, and so on. Clinical features of acute rejection, this is not so much relevant for autologous. I mean, not at all relevant for autologous, but it is important for allografts that you need to be very careful. Look at the lenticules, look for any epithelial rejection lines or any melting and epithelial defects. For treatment for rejection, usually topical steroids is useful. You can even do subconjunctival or subtenon steroid and systemic therapy. So the long-term success can vary from 0% to 75%. Strategies to improve the long-term success can be preoperative, intraoperative, and postoperative. We've done there's a systemic review by Dr. Basu et al. Looking at autologous limbal stem cell transplantation, a review of clinical outcomes with different surgical techniques. They did note that in the absence of RCTs, the best evidence would suggest that SLET is a little bit better than CLET. Another systematic review that our team had done had looked at all surgical outcomes for the treatment of limbal stem cell deficiency. And here the question was that the anatomical success rates are more or less similar with no statistically significant difference. However, the functional gain was better with SLET as compared to keratolimbal allografts and CLET. But here again, we did not find any RCTs. So this is a systematic review of non-RCTs, and there could be a lot of variations in the patient selection and protocols. So just to go back again, if you look at the direct lenticule applications, fibrin glue helps to augment the technique. It was a very fiddly technique earlier, having to suture with tenno nylon, but fibrin glue helps to stabilize it, and you can do autologous CLET as well. And so therefore, looking at unilateral comparison of the various options of autologous limbal stem cell transplant, a direct limbal lenticule versus a SLET versus a CLET, and you will appreciate that they all have good results. So it's a question of what is convenient to you and what is suitable for your patient. So ocular surface reconstruction, one example of a surgical video, thermochemical burn. If we have time, I'll show it. I'm sure all of you already know to do the surgery. Basically, you release the symblepharon very carefully. Be careful not to damage the underlying cornea. Sometimes when it's not visible at all like this, there may even be a perforation underneath. So UBM as well as ASOCT preoperatively can be helpful. So very gently dissect out. Try not to use a very sharp dissector. Sometimes you can get a very easy cleavage plane and the whole thing comes off very smoothly, particularly if the patient had been initially treated with amniotic membrane in the initial phases. But sometimes it can be very irregular, particularly if they're molten metal. So you have to be very careful, very patient, and release all the adhesions, and then remove the superficial pannus and then apply the cultured cells. In the interest of time, I will not show the entire detail. It is similar to what Dr. Lomi showed because the cells are grown on amniotic membrane, and fibrin glue has made the surgery much easier. I think we're over time. So this is the first day post-operatively. If there's a little bit of hemorrhage underneath, it doesn't matter. As we'd shown earlier as well, it clears up. And the choice of topical steroid, you can use a milder steroid if it's autologous. And 3 months post-operatively, you can see that the patient has done well, and with a contact lens can gain 6/9 vision. The donor site heals in 1 to 2 weeks and takes 6 to 12 months to replenish. So I'd like to acknowledge the stem cell facility at AIIMS, and Dr. Sujata Mohanty is the professor in charge, because they've taken a lot of the headache away from us in having to prepare the membrane in the eye bank and the various supports for all the culture work, etc. And with that, I'd like to thank all the speakers for having taken such efforts in preparing wonderful talks, and also the audience.